Hello, my name is Jorge Cortes, and we're going to be talking today about some of the novel information about the management of acute myeloid leukemia. And we're going to focus particularly on topics related to some of these targeted therapies that we have available today, specifically the FLT3 inhibitors, the IDH inhibitors. Others are coming, but these are available today. And I'm going to start with the FLT3 inhibitors, and just going back a little bit in history. As you all know, the first FLT3 inhibitor that was approved was midostaurin. Midostaurin was approved based on this study called the RATIFY study, which took patients with newly diagnosed acute myeloid leukemia, ages 18 to 59, with a FLT3 mutation, whether ITD or a TKD mutation, tyrosine kinase mutation, and they were randomized to receive standard therapy 3+7, alone or with placebo, and or in combination with midostaurin. And that same combination was used for induction, for consolidation with high dose RC, and then for continuation therapy. Of course, for the placebo arm, they continued just with placebo. As we all know, the results showed that the midostaurin combination was superior to the placebo combination. What I'm showing you now here is that with now 10 years of follow-up, that benefit remains for the patients that received the midostaurin. So that is very important to know because obviously the short term is very encouraging, but you want to make sure that these benefits remain over time. And you can see that these benefits in overall survival and by event-free survival remain even by the status of the FLT3. So very valuable information for the long term and shows that we really are impacting these patients. Of course, as you remember, many of these patients ended up receiving a stem cell transplant. So talking about the transplant, when you do the overall survival for the patients who actually did receive a transplant in first remission, you can see that there is a benefit for the patients that received the midostaurin, and that is a very significant benefit, and it extends really regardless of many of the characteristics that were evaluated for these different subsets of patients. And although I'm showing you the graphic for overall survival, it extends to the event-free survival. Now, one thing that has been somewhat controversial is the value of the maintenance or the continuation therapy. And what you can see here is that on the right side is the disease-free survival by the use of continuation. And there is not much of a difference there in disease-free survival. I think there are reasons why this happened, and when we get a little further along in the presentation, I'm gonna get into more details of why I think this overall curve is like this with midostaurin. But regardless, we know that midostaurin is not approved for the continuation therapy based on these data. So the next drug that was approved for this indication, the same indication, is quizartinib. Quizartinib was originally studied for refractory relapse AML. It is effective in the salvage setting, and although the salvage study called Quantum R hit the primary endpoint, which was the overall survival compared to standard chemotherapy for patients with refractory or relapse AML, it was not approved for that indication. But then this study was designed, which is called the Quantum First. Very similar design to the one that I showed you for the midostaurin. One big difference is that this includes only FLT3 ITD. Quizartinib does not have a benefit for the patients with kinase domain mutation, that DA35 mutation. That's a minority of patients, but it is important to keep that in mind. This is what we call a type 2 inhibitor versus a type 1 that covers both mutations like myristoyl or gilteritinib or some of the others. Anyway, so these patients were, again, randomized to receive either chemotherapy alone, or I should say with placebo, or chemotherapy with quizartinib. You will notice that the age goes all the way to 75 here. Of course, these were 75-year-olds that were eligible for intensive chemotherapy. But then the same continued with consolidation, again with high-dose cytarabine, and then with maintenance or continuation of therapy. And the primary endpoint of this study was overall survival. And you can see that these results that have already been published and presented previously showed a benefit in survival for quizartinib. So that led to the approval of quizartinib for this indication. Well, in recent meetings and presentations and publications, we are learning more about some of the specific, the details, the particular populations and contexts where you see the most benefit for quizartinib. And that is important to keep in mind, because patients are not all the same, even if they all have the FLT3 mutation. So one of the common themes is that these mutations don't happen in isolation. Patients frequently have other mutations. They have NPM1, they have DNMT3 mutations, they have P53, they have other mutations. So what happens in the context of FLT3 mutation when the patient may have, in addition, another mutation? Well, that's what I'm showing you here. This is new data that we presented at ASH in 2024, so about 6 months ago. And as you can see, both for patients that have NPM1 mutations in addition to the FLT3 mutation, or who have DNMT3 mutation in addition to the FLT3 mutation, in both instances, the quizartinib survival benefit is still there. And if anything, if you see those curves are a little bit more separated than for the overall population. And then for those patients, and there are fewer patients, but when they have both mutations, NPM1 and DNMT3, again, all in the context of a FLT3 mutation, so 3 mutations here, you can see that the patients that took quizartinib have a better survival. So it looks like the more mutations, the more the benefit that you see with quizartinib in these patients that have as a background a FLT3 mutation. And here you can see the different other mutations. There's many others. And for the most part, you can see that all of them have a trend to benefit quizartinib. Some of them, the benefit is not statistically significant because you're starting to get into very small numbers. The one exception that I think stands out a little bit and it's interesting is ASXL1. ASXL1 is a tough mutation. And curiously here, if anything, the trend is in the opposite direction. It looks like it benefits actually the placebo combination. Whether that's an artifact or not, hard to tell. But certainly there doesn't seem to be much of a benefit for quizartinib in those particular patients that have ASXL1 mutation. So this is I showed you the survival. Now here's the response rate. And you can see the same kind of trend, regardless of what mutation the patient has. In addition to FLT3, there seems to be a trend for benefit. It is more in some of the less common mutations. There is a bit of a trend, although it's not as strong as for survival in terms of the complete remission, the composite complete remission. Now, there are patients that have, there are many other epigenetic mutations. We talked about DNMT3, but there's also TET2, there's also WNT1, there's IDH1 or IDH2. All of them have an epigenetic mechanism of action. So if you, on the left, you see here what I showed you earlier for the NPM1. But if you have NPM1 and any of those epigenetic mutations, I had shown you NPM1 and the NMT3, but because there's many other mutations, you can see that with any of the other epigenetic mutations, that benefit for quizartinib remains. And again, it seems to be even a bigger difference compared to just the FLT3 mutation. So very important to evaluate all the mutations, and certainly it helps that quizartinib works in these more difficult scenarios. Well, that is with standard chemotherapy. Of course, more and more we are using azacitidine and venetoclax, certainly for patients that are unfit for intensive chemotherapy. We know that there's been one study that has investigated gilteritinib with azacitidine. Gilteritinib is another type 1 inhibitor, like midostaurin, meaning it works against either type of mutation. And it is approved for salvage therapy, not yet for frontline therapy. It is approved for salvage therapy for patients with FLT3 mutated disease. Well, here in this study, it's the exploration of gilteritinib in combination with azacitidine and venetoclax. A randomized study of azacitidine plus gilteritinib versus azacitidine plus placebo did not show a benefit for gilteritinib. But what about in this triplet combination, where you give the combination and you continue the consolidation with the same combination? Keep in mind that there's dose adjustments and all of that you need to do, because this is more myelosuppressive. But the results, granted, this is a single arm, this is a single institution, and we need to keep that in mind. But the results are pretty impressive. The rate of composite complete remission is very high, 93%. And the other ones are at least morphologic leukemia free. So an excellent outcome with this triple combination. And of the responders, the great majority, 81%, ended up having a FLT3 negativity. You see here the FLT3, the relapse-free survival and the overall survival. Very, very good medians. The median survival is in excess of 3 years. These are patients unfit for chemotherapy, so this is a particularly bad patient population. So very, very interesting results. Of course, it'll be good to see follow-up and at some point some randomized studies to see how it would compare to, for example, AZA venetoclax alone. Now, talking about the impact of additional mutations, the patients that have RAS mutations in addition to a FLT3 mutation, these patients don't do as well. Their median survival is only 2 years, which is not bad, but certainly it's not as good as the patients that don't have a RAS mutation, where the median survival is over 50 years. So again, very important to assess patients with a full panel of mutations to better assess their outcome. And this is important because you can see with these survival patients without a RAS mutation, considering these are patients are not fit for intensive chemotherapy, you're not as pressed to do a transplant in these patients. Of course, if you can, that's still probably today beneficial. Another triplet was a similar concept, except here with decitabine instead of azacitidine, and with quizartinib instead of gilteritinib. So half-methylating agent, venetoclax, and quizartinib for patients with FLT3 ITD. Here is only ITD. Again, quizartinib only works against that mutation. So similar concept, and adjusting the doses. Actually, they ended up adjusting the doses in the middle of the study because of the more severe myelosuppression. So the quizartinib, for example, is only days 1 to 14 in the second part of the study to minimize the myelosuppression. And there's two cohorts. There's the refractory relapse and the newly diagnosed cohort. And the results are, again, very impressive. The CRC is 94%, also, very similar to the one that we saw. For the relapse refractory, it's 60%, which, considering that these are refractory relapse, is also very impressive. And the MRD negativity by flow or by PCR are around 60%. So very, very good results with these triplet combination that allows many patients to get to a stem cell transplant. You see here the overall survival. and which is excellent. Actually, it seems to be even better for the patients without a transplant. Of course, the early data always favors the chemotherapy. We need to see the longer term data where you may be seeing more relapses without the transplant and eliminate the early mortality from transplant. In the refractory relapse cohort, obviously, as we would expect, the patients that have a survival, that have a response are going to have a better outcome. And you see that here in terms of overall survival. And also the patients that have a history of exposure to high methylating agents or venetoclax, plus venetoclax, have a worse outcome. That's not unexpected because they already received 2 of the 3 drugs. Also, the patients that had prior gilteritinib have a slightly lower probability of survival. So definitely those prior exposures affect the survival. One very interesting study talking about FLT3 inhibitors is this study called the KIWI study. This is a study that takes advantage of an observation that we published many years ago, that as a single agent, quizartinib has a 30% response rate in patients with refractory relapse acute myeloid leukemia that do not have a FLT3 mutation. So for the unmutated patients, of course it works with the FLT3 mutated, but these are patients without a FLT3 mutation. So that observation is taken into this randomized study in which it's a very similar design to that Quantum First study that I just showed you in terms of being chemotherapy alone or in or with chemotherapy with placebo or with quizartinib. But these are patients that do not have a FLT3 mutation, they do not have an ITD. And as you can see, there is a survival benefit and there is an event-free survival benefit. Both of them are statistically significant. Very good outcome, and in a way, somewhat surprising, although not considering that we already had reported that as a single agent works in non-FLT3 mutated patients. So one of the questions is, why does it work? And that's interesting. Now, before I get to that, I'm showing you here the benefit in patients that, in addition, have NPM1 mutation, that have an NPM1 mutation, that have a DNMT3 mutation, or that have a FLT3 TKD mutation. Remember, this is a type 2. I told you that it's not supposed to work there. And yet, you see a benefit on these patients that don't have FLT3 mutations, but have one of these other mutations. P53 is a tough mutation. In that setting, it doesn't work any different than placebo. IDH patients, they don't have such a poor prognosis, and in that context, it doesn't seem to add benefit to just the chemotherapy. So there are settings where it works better than placebo. There are settings where it really doesn't add anything. So again, the question is why? Why are these patients responding? Well, these investigators, this study comes from Spain, from the PETIMA trial, from the PETIMA group. They looked at the genetic profile of patients in this KIWI study. And what they found is that the patients that there is a subset of patients that have a genetic expression profile that is very similar to patients that have a FLT3 mutation, except that they don't have a FLT3 mutation. But the expression of other genes is very similar to patients that have a FLT3 mutation. And those patients in particular that have this FLT3-like genetic profile are the patients who benefit from using quizartinib. So that is important because if these can be validated and perhaps incorporated into a more simple genetic profile, this could help us design what patients would be beneficial to give them quizartinib in addition to chemotherapy when they don't have a FLT3 ITD mutation. And actually, there's a large study that is going on that's called the Quantum Wild, which is trying to replicate this data, confirm this data, and also further investigate this issue of the FLT3-like profile. So in this study, you have patients that are FLT3 not mutated, and they're randomized to receive either chemotherapy with placebo or chemotherapy with quizartinib, and then there's three arms because one of them continues with quizartinib in maintenance. The other one does not receive quizartinib during maintenance. So that'll be a very interesting study to see as the results come out. But that study is ongoing right now. Another important question is we have a number of drugs nowadays. We talked about midostaurin, we talked about quizartinib, and we talked about gilteritinib. Are there any differences between them? So this study from ECOG is trying to answer that question in patients with newly diagnosed AML with a FLT3 mutation using chemotherapy, standard chemotherapy, with midostaurin or with gilteritinib. Again, gilteritinib is not approved in that context, but it's a good FLT3 inhibitor, a very good FLT3 inhibitor. So the question is there a benefit from one versus the other? We know gilteritinib is more potent and quizartinib even more potent than those. So you would expect that perhaps there would be a benefit. Well, the results showed that in terms of the response rate, there is a trend for a better CR rate with gilteritinib, 75% versus 65% with midostaurin. So that would favor the gilteritinib. However, when you look at the MRD negativity, the results do not show a benefit for gilteritinib, and if anything, there is more patients with FLT3 negativity in the midostaurin cohort, and this is FLT3 by PCR. So it is curious that yes, you see more responses with gilteritinib, but they're not as profound as the responses that we see with midostaurin. I think the overall, and we'll have to see longer follow-up so we can get event-free survival and overall survival and all these long-term outcomes. But right now with these data, it would appear that these drugs would be more of equivalent than having a superiority of one or the other. Now, this is the data with gilteritinib that I mentioned earlier that resulted in the approval of gilteritinib as a salvage therapy. Patients with refractory relapse disease with a FLT3 mutation that receive gilteritinib alone or with standard chemotherapy. So this is the proper indication today for gilteritinib. There was a recent analysis that looked at this study in the context of Asian patients. We know that the Asian population has different characteristics. Their body mass is different. Their genetics are different. Their metabolism of drugs is different. So the question on this report was whether the results apply to that particular subset of the population. And the answer is yes. You can see there that the survival is similar to what we saw in the overall population that I just showed you in the previous slide. And you can see that more clear here. So that is encouraging. That is a good thing to see. Now, going to the topic of the maintenance, as I mentioned, all these studies, and here I'm referring specifically to the gilteritinib, use gilteritinib, allow the use of gilteritinib as maintenance. Now, this is a study that specifically looked at using gilteritinib after transplant. That's called the MORPHO study. So patients with FLT3 ITD, they got whatever treatment, they went to transplant, and they received gilteritinib after transplant or placebo. As you can see on the top left, the relapse-free survival there's a trend for improvement, but it's not statistically significant, and there is not overall survival. And the reason for no overall survival is because although there is a lower relapse rate with gilteritinib, there is a higher non-relapse mortality with gilteritinib. So that balances each other out. However, you can see at the bottom that when you divide at the right bottom, when you divide the patients according to their MRD, the patients that go into transplant that are still MRD positive, they benefit from gilteritinib. The patients that are already MRD negative after transplant, they don't benefit from gilteritinib. So that is the guide of when you would like to use gilteritinib and when you don't get a benefit. And that, of course, makes sense. When they're MRD positive, you will be able to rescue some with the gilteritinib. So very important observation in my opinion. And here you see somewhat the same thing. But I want to focus on the far right, where you see that there are patients that they have MRD positivity with only one clone or with multiple clones. And they looked here at these patients that have one clone or multiple clones. So in the far right, at the bottom, the curve marked with C is the placebo patients. So if they are MRD positive with one clone or with multiple clones, they do much worse than if they're MRD negative. With gilteritinib, if they're MRD negative, of course, just like with the placebo, they do well. But if they have one clone, they do well. They do as well as if they don't have MRD positivity. But if they have multiple clones, those patients don't do as well. So again, it's not only the MRD positivity, but this number of clones that determines the benefit of the use of gilteritinib after a stem cell transplant. All right, I'm going to move now to IDH. We've talked about FLT3, and now this is IDH. We know that we have 3 drugs approved for IDH mutations, and axitinib for IDH2. We'll talk about that later. And then ivosidenib and olutasidenib for IDH1. Ivosidenib is approved for as a single agent for refractory relapse, and also in combination with azacitidine in frontline. This study explores the combination of the triplets, ivosidenib plus azaven with two different doses, or ivosidenib with just ven as a part of the dose escalation of this phase 1 study. So these are patients with refractory relapse disease, and after the selection, they continued with the therapy. And as you can see there, the triplet is what's continuing for the combination. But let me show you the results. You can see here that the results are very good. They started with a phase 1 in the refractory relapse, and now there is a cohort already with newly diagnosed. And you can see excellent results. The best response, the CRC in newly diagnosed is 94%. In refractory relapse, it's 83%. So excellent results. And then the MRD negativity by flow for those 2 cohorts is in excess of 75%. So very good. You see a little bit less in terms of MRD negativity for patients that have either MDS or MPN with IDH mutation. The overall response rate is also good for that cohort, but they're not as high rates of MRD negativity. Again, looking at subset analysis by presence of other mutations, and you can see here that if there's NPM1, equally beneficial with or without mutation. For P53, if they have mutation, they don't do well. That's a tough mutation, as we said earlier. And RAS mutations also decrease the benefit. Also a difficult mutation to address, even in this context. Now, olutasidenib is the newest of these drugs that has been approved. And what we reported here on this abstract at ASH was the time to response. And that is important because we need to remember these drugs are more of a differentiating agents. So the responses may take some time. So what happens when you haven't achieved a response after 1 or 2 cycles? Well, as you can see, there is a subset of patients that take more than 2 cycles or even more than 4 cycles, more than 4 months to respond. So the response continues to improve over time. And when you look at the outcome in terms of the survival by the time to response, you can see that patients with a long time to response, which is the red curve, do as well as the patients with a short time to respond, which is the blue curve. So the message here is that patients that have stable disease but not yet a response, you should continue therapy. And that's not just olutasidenib, that's with IDH inhibitors in general, because they may respond later, and those late responses may still have the same value that the early responses. The most recent data with olutasidenib shows an overall response rate that's very good. The one thing that stands out with olutasidenib is that there's more CRs than CRHs, which is a little bit different than what's been reported with ivosidenib. So there seems to be a higher CR rate and a longer duration of remission with olutasidenib compared to what's been reported with ivosidenib. They've never been compared head to head, so that needs to be considered. But that seems to be a benefit for olutasidenib. But olutasidenib also has been used in combination with hypomethylating agents, and this is the data that was just published just a couple of months ago. These are small cohorts, but it shows you that you can get very good responses in patients with refractory relapse AML with olutasidenib plus hypomethylating agents, particularly in those who have not received previously either a hypomethylating agent or an IDH inhibitor, or in the treatment naive, of course. Now, the response rate of 40 to 50% in patients with prior hypomethylating agents or prior IDH is not bad at all, but certainly it's a little bit lower than if they have not had those exposures. Olutasidenib also can improve the transfusion requirements, so that's what this complex slide is showing you, and even in some patients that have not had a full response. So keep in mind that that's an additional benefit of olutasidenib. And then there's the interest on these triplets, and this is just at the moment a trial in progress. But just like I showed you, the cytarabine, venetoclax, ivosidenib, there is an ongoing study using olutasidenib in that triplet combination. Finally, enasidenib, this is the IDH2 inhibitor, and this is a randomized study comparing it to standard chemotherapy in older patients with IDH2 refractory relapsed AML. And as you can see, although the difference is modest, there is a benefit for the patients treated with enasidenib. And of course, this is in terms of overall survival and event-free survival, but also the tolerability is much better for enasidenib compared to the standard chemotherapy. And this is a combination with azacitidine, where you again can see very good responses, definitely in the newly diagnosed, small cohorts, but as a starting point, very, very interesting data. And the relapse refractory also almost 60% CRC rate with the combination. It works better if you add venetoclax, as you can see on the bottom right curve, the blue line compared to the pink line, which is just enasidenib and azacitidine. So the triplet also seems to work better for this combination. So that is the update on these inhibitors of targeted changes that I think have opened great avenues for our patients with acute myeloid leukemia. I thank you for your attention.